All right, June 12th, 2024. I'm an intern in residency. I'm about to be a second year. So I wanted to talk about diabetic ketoacidosis a little bit. It's one of my favorite disorders, and this is how I think about it right now. And I'm sure in the coming years it will change. So I like to think of DKA as a disorder of shifts, not just fluid shifts, electrolyte shifts. It's really cool. I'm going to be talking about that later, but I'll first start with just presentation, treatment, and then I'll get more into physiology and a lot of the cool stuff later, as well as just different technical considerations and variations that other people like to do with the disease. So, diabetic ketoacidosis patient comes in, they have nausea, vomiting, abdominal pain. You look at them, dry mucous membranes, they're going to be in pain. They might be altered as well. So, what do you do? Quickly get chest x ray, your CBC, your chemistries, your MAGFOS. Maybe check a lactate as well. See their vitals, see how they're doing. So, why did I do those things? So, chest x-ray to rule out to see if it's an infectious cause. You're going to want to talk to the patient. What precipitated this DKA? Was it did they get sick recently? Some open wounds. They're going to be diabetic, so they're going to have a lot of these open wounds. Maybe they'll have ulcers, stage 1, stage 2, stage 3. Maybe they see a podiatrist. Maybe we need to get to see if there's osteo involved. Maybe it's just medication non-compliance. They just ran out of their medications. It wasn't getting approved by insurance. Maybe they just forgot or couldn't access it. Maybe they just ate something that shot them upwards, did something that they normally do, some kind of trauma, some state that threw them into this. CBC, just really the white cell count to see if there's an infectious cause. Chemistries, you want to be starting the ball rolling. You want to check their potassium. That's going to be the most important thing. If you look online, there's guides for different cutoffs of potassium that you want before you start an insulin drip. Generally, like if it's above 5.5, 6.5, you don't have to do anything before starting an insulin drip. If it's lower, if it's like 4.5, 3.5, then you're going to be wanting to give some potassium before you start the insulin drip. What about hyperkalemia, right? So generally, you shouldn't be too worried about hyperkalemia. If they come in with potassium like 7, you generally don't need to do anything. In fact, it might be harmful to do stuff, right? So if they're hyperkalemia, you might reflexively want to do a hyperkalemia cocktail. You might want to give calcium gluconate or Lokelma as well as insulin and bicarb. But my question for you, is it really needed? One, you're already going to be starting insulin drip. It'll be moving the potassium in naturally. And over the course of time, generally insulin drips are run for a couple hours. The potassium's going to go into the cells. Two, there's going to be bicarbonate shifts. If you give bicarb and lower the potassium, you might lower at a very, very fast rate. So in acidosis, H plus goes into the cells and K plus goes out. So technically, even though your serum potassium levels are elevated, your total body potassium is low because in this acidotic state, all your potassium is going outside of the cell. And then three, I challenge you: why shouldn't you give potassium or like the bolus? Is what I was saying, because total potassium is high. Serum potassium is high, but the intracellular potassium is low. So you might actually want to be repleting in this case, and then an extra, well, calcium gluconate or Lokelma might not hurt. It might not be necessary. And you might actually be diverting your nurse's attention away from doing things that actually matter, like getting the insulin started. You might be diverting your pharmacist's attention from things that matter. They might be calling about the Lokelma, the calcium gluconate. It's really not necessary. You should just focus on the main issue at hand, starting the insulin drip as soon as possible. We've talked so long, but there's more things on the chemistry: potassium, magnesium, phosphorus. Those things just replete as necessary, right? So, but you don't want everything to be falling. You don't want potassium, magnesium to fall. You don't want to precipitate any arrhythmias, right? Sodium is also important. All right, so sodium in hyper and DKA is pretty cool. So this chemistry panel I can talk about for a very long time because it's like wildly weird in DKA. Sodium oftentimes is going to be low, but it's going to be something called pseudo hyponatremia. It's not actually a low sodium because glucose is going to be elevated in DKA. Glucose, let's say 300. There's going to be a correction factor for the sodium because the glucose is pulling in water. So technically, the sodium level is not going to be elevated. It's not going to be low. It's going to be the water pulled in by the glucose that's going to lower the sodium. So for every 100 points above 100 that the glucose is, you can multiply by zero point 0.2 and then add that to the sodium. So let's say their sodium's 133. Are they hyponatremic? Their glucose is 300. It's 200 above 100. 2 times 2, that's going to give you 4. So you add 4 to the sodium. That'll give you 137 sodium, and that's normal. So it's a complex interplay. I'm actually going to get into it now. There's fluid shifts in potassium too, right? So we just talked about total serum potassium being high, but total potassium being low. That's because of these shifts with the H plus K plus causing the potassium to leave the cell and for the H plus to come in. Right. Magnesium is also going to help too. Magnesium is going to help you replete your potassium because of the ROM-K channels. All right. So now we move on to starting the drip. How do we start the drip? We want to stratify by mild, moderate, or severe DKA, and then you can worry about how fast you're going to go with the insulin. So generally, mild, moderate, severe, you can look online for different like breakdowns. I don't know them off the top of my head, but they're classified based off of 4 main factors, and that's going to be your pH, it's going to be your carbon dioxide, so your bicarb level, how acidotic were you, your anion gap, as well as the beta hydroxybutyrate. So DK is cool. Beta hydroxybutyrate is made in the anaerobic cycle of glycolysis. It's going to be made from the keto acids. It's going to be acetoacetate, acetone, which is going to give you the fruity odor, and then it's going to be beta hydroxybutyrate. So your pH is generally going to be low. HCO3 is going to be a metabolic acidosis, and it's going to be anion gap. But the important thing to remember is, why is it an anion gap metabolic acidosis? It's because of the ketones, diabetic ketoacidosis. It's the key problem to this condition. And it's the reason why you don't give bicarb too. Generally, you don't give bicarb. It's because you're trying to lower the ketones. That's the anion of concern. It's not lactate, where bicarb may help. It's the anion gap of the ketones. So generally, you should be looking to see if this is a pure anion gap metabolic acidosis, and if you feel that beta hydroxybutyrate is the major player, then you should really lay off the bicarb. But if perhaps there's a component of lactate, perhaps they were having such bad diarrhea that precipitated them into DKA, that would be non-anion gap. But let's say they were so hypoperfused, they're in sepsis, and maybe their lactate is up, then maybe consider bicarb. But in general, don't consider bicarb for DKA. Focus on the insulin, focus on the problem at hand, which is the beta hydroxybutyrate. So now that we've looked at it, generally you want to start and insulin drip, right? So insulin drip, fluids, potassium. That's going to be the mainstay of treatment. How do you determine how much fluids to give? There are various algorithms online with fluid that you start ranging anywhere from like 100 milliliters per hour to 250. DKA is one of the disorders where you give a lot of fluid. There's few other conditions where you give this much fluid and where you'd be scared to give this much fluid too. Those being acute pancreatitis, sepsis, and DKA. Think of these as the disorders of where you want to give a lot of fluid. The body can afford to have more gas in the tank. So you give fluids. The rate, generally, you want to give 10 milliliters to 20 milliliters per kilogram per hour. It's almost a mini sepsis dose, sepsis bolus, but you're giving this over 1 to 2 hours. Generally 100 to 250 milliliters per hour. What fluid do you choose? Because patients generally going to be hypervolemic, fluid resuscitation is key. You can choose something such as NS. Why not choose NS? It's because NS can cause a non-anion gap metabolic acidosis. This anion gap can make it hard, non-anion gap can make it hard for you to know when the pH is closed because you can cause precipitated acidosis. However, generally pH is the last thing, is like usually the first thing to close, last thing you worry about. So the anion gap and the bicarb generally will close later. So NS is a good fluid for resuscitation, and because DKA has many stages, usually in the first stage, NS is a good solid choice, especially since usually sodium's not a problem. You're going to usually have hyponatremia, and even if your sodium was normal, that generally indicates more dehydration just because of the glucose pulling in water. And then glucose pulling in water, so you lose it through your urine, but also it pulls in water into your intravascular space. So sodium's generally going to be lower than what it is. You give fluids. You can give LR if you're really concerned about the acidosis, but NS is generally what people choose. But you wouldn't be wrong if your argument is to say NS can cause an AGMA, so let's stick with LR. You, during this whole time, you're checking your BMP Q4 hours. So fluids, insulin, and potassium. Replete the potassium, magnesium, phosphorus as needed, as fast as you can. So potassium, giving K riders like IV potassium chloride, 10 ml equivalents, as much as you need. Magnesium, 2 grams magnesium sulfate IV, as many as you need. Phosphorus, Nutrifos packets. You're going to be checking the glucose every hour. You generally don't want the patient to be eating because you have to think about DKA as kind of landing a plane. You want everything to be well controlled. You want to be checking periodically the glucose, potassium, magnesium, phosphorus. You'll lose control if you allow the patient to eat. If you're bringing their glucose down from 300, you won't know how well the insulin drip is doing if they eat like a piece of candy or chocolate. That's just going to shoot their sugar up. Once the glucose goes from 300 to 250, 250 is going to be when you have to drip. So going from 0.0 units per kg, you lower it down to 0.05 units per kg per hour. That's going to be a lower rate. And then you're going to be doing this the whole time, checking your potassium, magnesium, phosphorus, repleting as necessary. And you can change the fluids at this point. At this point, they should be adequately volume resuscitated. It might be a couple hours now of a high amount of NS. So you can go to half NS or LR. Still going to be a generous rate, 100s to 200s, depending on what algorithm you have, depending on how volume down that you feel that they are. And if they ever go below 150 glucose, then you're going to add some D5 to it. And you might be wondering, why are we adding glucose to hyperglycemia? But it's not hyperglycemia, it's DKA. So really you want the ketones to close, and you'll do anything to close it with the insulin, including having to give extra glucose and dextrose as needed. So you can add D5 to the half NS or D10 half NS, and you can go and adjust the rate of the fluid as needed to maintain the amount of glucose to make sure that they're not going hypoglycemic. All right, how to assess resolution of DKA. pH normalize 7.35 to 7.45. Try to get that twice, or bicarb greater than 18 about twice. Make sure the anion gap is closed, less than 12 about twice, and beta hydroxybutyrate closed, but generally people don't check the beta hydroxybutyrate again. Once these things have closed twice, you feel like you've securely landed the plane, because if you just have it once, maybe the plane bounced off the runway and is taking off again. You have a very bad plane, right? But if it's closed twice, you can feel that it's securely on the runway and that it's not gonna um, take off again. You would, before the plane touches the runway, kind of letting the tires off, is you would start their home long acting insulin. So once those criteria have met, then you can start their home glargine, whatever it is, 30 units, 40 units. Give the basal first. If they're not on home glargine or you don't know what the dose is, give 0.2 to 0.4 units. Or you can do something fancy and calculate how much insulin was given over the past 24 hours. And then, or the past how many hours, and extrapolate to 24 hours and give that to the patient. But generally, you want to divide by 2 because some of the insulin will be stuck to the tubing, and you don't want to give them too much insulin, or they'll go hypoglycemic. Now you'll have the opposite problem. This is a very delicate landing of the plane. You can bring their sugar down too quickly and completely crash the plane. But also, if you don't bring it down and land it flat long enough, it can take off again. So you started their basal insulin, wait 2 hours, make sure that everything is closed still, and then you can allow them to have a diet. And now you've successfully landed the plane. You went from 0.1 units of insulin. Their sugars have gone from whatever 300s to 250. Then you halved it to 0.05. You changed the fluids to from NS to half NS, and maybe you went down a little too quickly, so you needed to add some D5 NS to bring the plane back up. But then once you ketones and everything closed, once your pilot felt like you are very secure on the runway, then you can begin to add the glargine, which is kind of like deploying the wheels to the plane, and then you've landed 2 hours later. Congrats, you've treated DKA. So that's really good. Some considerations, right? So you want to make sure that this DKA doesn't come back, that they don't precipitate it again. Make sure that you know the reason for the precipitation, that if it was insulin noncompliance, that you're able to give them, get them the insulin they need, the teaching, work with the diabetes educators. A lot easier said than done, but this is something that will be tough for you going forward. Treat the infection if it was from infectious cause, right? So we talked about why we use NS. It's mostly for fluid resuscitation. Downsides, it can cause NAGMA, but it's not a wrong answer. We've talked about why we generally don't give bicarb in DKA. Unless their pH is like 6.9 and life-threatening, or if you feel like there really is another cause for anion gap metabolic acidosis aside from the ketones. We talked about the fluid shifts, the electrolyte shifts. There's a ton in DKA. So extra glucose is bringing in a lot of water. It's lowering the sodium. The sodium can be corrected with the formula, like 1.6 to 2.4 times the amount of hundreds over 100 of the glucose. We've talked about the cellular shifts for potassium. Potassium, if there's a lot of acidosis, potassium will be outside of the cells. there'll be a lot of serum potassium, but low actual cellular potassium, low total body potassium, but high serum potassium. We talked about the need to replete magnesium, phosphorus. So, yeah, it's a cool disease. We'll see how much I enjoy taking care of it in the future. Generally, if you get someone with DKA, that's going to be someone who requires a lot of attention. You'll probably take the whole shift, 12 hours, probably more, to get the patient to close their gap and to bring them down to the landing. But it's really cool to land planes, So thank you.